Okay, hello and welcome everyone to the workshop, Exploring the Potential of AI in Healthcare Improvement. It's fantastic to see so many of you on the call. I think there's a few more will be joining us over the next few minutes. So I'm Matthew Hill. I'm the Head of Insight Evaluation and Research in the Q team, and I'm really delighted to be chairing this session. We've got a great mix of Q members and some non-Q members here today. Everyone is very welcome. For those of you who aren't yet members of the Q community, we'd really love you to join. We have over 5,700 members across the UK and Ireland, all collaborating to improve the safety and quality of health and care. We share our knowledge and support each other to tackle challenges so that together we can make faster progress to change health and care for the better. So if that sounds like a community that you want to get more actively involved in, please do join us. And I think one of my colleagues is sharing some more info on that in the sidebar. Just a few things to kind of set up the session. So please do ask questions throughout in the sidebar as we go. We'll try to get to as many of those as we can, but just add them as we go. There are closed captions available. So if you would like them displayed, please click on the bottom of the screen under the More section and you'll see the CC button. If you do have any technical issues, you can ask for help in the sidebar and we'll do our best to help you. And finally, we are recording the workshop. We won't be recording the breakout rooms, but we will share the recording alongside the slides and some other useful links in an email after the session. So I'm really pleased to introduce our expert panel who've been leading a lot of the work and thinking on AI in health at the Health Foundation. So we're joined by Tom Hardy, Senior Improvement Fellow, Nell Thornton, Improvement Fellow, and Ahmed bin Ismail, Senior Improvement Analyst, all at the Health Foundation. So we're really grateful to them for joining us today. So in the workshop, we're going to cover an accessible overview of AI, really trying to break down what it is, why people are excited, as well as how it can be applied in healthcare. Set out some of the key risks and challenges that we need to address to harness AI in a responsible way. And explore the potential for AI for improvement specifically. And we have got some time for discussion about how AI relates to your own improvement work at the end of the workshop. Just before I hand over to the panel, let's just find out a little bit more about where everyone's at in terms of AI. So please access the Slido link that you can see on your screen at slido.com. You can do it on your computer or your mobile device and just enter the code hashtag AI health. We've got these two questions that we want you to answer. So if you can just go onto the Slido and do that, that'd be great. And Char's just going to share a screen so we can see some of the results. So the first question, and the answers hopefully will be coming through any second. What, if anything, are you currently using AI for within your role? Obviously, for some people that you won't be applying it at all in your role, and obviously that's fine. But it'd be great to hear if there are any examples kind of on the call of people using it. Not so much so far. We'll give it another minute or so. Okay, this is a good base for us to start then in terms of very little kind of use in people's work. At the moment, a couple coming through. Yeah, support with kind of written work. Searches and summaries for information. Yeah, just playing around with it. At the moment, it sounds like a few people maybe have had a go at kind of ChatGPT and Copilot only. Okay, great stuff. So we'll move on to the second question, which is, to what extent do you agree with the statement, I look forward to using AI as part of my role? So that's hopefully something that most people have a view on. So how are you feeling about the kind of future in terms of AI? Keep those coming through. It looks like those responses are settling down. I mean, in a report published last month, actually, by Nell, Ahmed and Tom, they found that 57% of staff agreed with this. So very, very close to this group in terms of the level of optimism. In that report, it was 24% of all staff neither agreed nor disagreed, and 17% disagreed. So actually on those two, this group is slightly more kind of positive and optimistic about AI, but generally the same. And actually from that report, there were some interesting differences in terms of different perceptions of different roles. Okay, great stuff. Well, that was just a bit of a warm up to find out where we're all at in terms of AI. Now I will pass on to Tom, Nell and Ahmed without further ado.
Thank you, Matt. I'll just share my screen. Hopefully everyone can see the screen okay and can hear me nice and clearly and can see me.
Yeah, that's great, Ahmed.
Perfect. So just to get started with a bit of an introduction to what we'll be looking to cover today, we think it's helpful to start with the definition of AI, cover some artificial intelligence misconceptions that we've seen occur. We'll also be looking to provide some examples of artificial intelligence in healthcare. And then we'll be using the rest of the time today for the presentation to share a couple of case studies, to discuss the risks, share some of the findings from our survey that Matt referenced already, exploring public and staff attitudes towards AI, the need for an AI strategy, and some considerations to think about as well, particularly when we're thinking about quality improvement. So starting off, what do we mean by artificial intelligence? We use the International Commissioner's Office definition as an AI being an umbrella term for a range of algorithm-based technologies that solve complex tasks by carrying out functions that previously required human thinking. And a key distinction or a critical aspect of the definition is the capacity to mimic human thinking. And this is what really distinguishes AI from other types of technologies. And just taking the definition further, what do we mean by an algorithm? And this is a set of processes or set of rules to be followed in calculations or other problem-solving operations. And an easy way to visualize an algorithm is to think about the recipe card here on the right, which has a clear set of instructions from mixing ingredients to removing from the oven, letting it cool, and eating. And that's essentially how an algorithm works. It follows a set of instructions, and that's the basis for artificial intelligence. So moving on to some artificial intelligence misconceptions. And there are a lot of them, but we've chosen to highlight a select few that we've seen recur quite frequently, particularly from our research or through engagement with different stakeholders. And the first one is that AI is the same as robotics, or a lot of you might be familiar with the term RPA, robotic process automation. And so while AI and robotics are related, they're not the same thing. AI relates to computer programs and algorithms that are designed to mimic partial aspects of human intelligence, tying that back into our definition of mimicking human thinking. Whereas in contrast, robots are physical machines that perform often repetitive tasks. And although many robots are equipped with AI, not all AI systems are embedded in robots. And on the contrary, an overwhelming majority of all existing AI systems do not operate a physical object, but work purely in a digital manner. Another term that comes up is what I referenced, the RPA, the robotic process automation. And although robotic features in the name, it's a slight misnomer in that it's not a physical robot that is being referred to, but a software technology that automates processes such as the transfer of data from one system to another. While RPA can be augmented with AI, a lot of RPA doesn't have AI within it. A second misconception is that AI will take everyone's jobs. And we're looking at this more specifically through a health context. And previous Health Foundation research has shown that while technology and AI are unlikely to lead to widespread job losses in healthcare, particularly as the portfolio of tasks that people hold are quite broad, it is instead likely to transform the nature of people's work. However, in different contexts, the level in which AI can transform roles will vary. And then the third misconception is that AI is a completely brand new concept. And with the sort of rapid rise of ChatGPT and its popularity, we're here in 2024, this is the perceived timeline, and ChatGPT was released to the public. It's easy to think that it is a completely new concept that's been channeled over the last couple of years. But the history of AI and how old the concept actually is may surprise some, because it actually looks something like this. Going all the way back to 1950, Alan Turing published a landmark paper speculating that machines could be built to think, which again ties in with that definition of what we mean by artificial intelligence and linking to human intelligence and human thinking and the capacity to do that. And in between 1950 and 2022, we have this sort of roller coaster of a journey for AI, where in 1956, we had the sort of birth of AI, an AI winter where sort of investments were stopped or funding had kind of stopped. Then we had an AI boom in the 80s. And in kind of the 80s, 90s, there was a second AI winter where lots of companies collapsed because funding was withdrawn. And then in the 21st century, we've seen a lot of advancements in sort of AI research, developments in machine learning technologies, and then to where we are in 2022 and 2024. And an interesting pattern to note as we sort of look at this timeline of AI is that whenever we've seen a boom in AI, so in 1956, it's often followed by a bust. And we're currently now in a boom where a lot of AI's technologies are being driven forward. And it's not to say that we will have a bust, but a lot of the excitement or enthusiasm may abate over time as risks and challenges become more apparent. And we'll be looking to cover some more of those risks and challenges in a bit more detail later on. So going on to some examples of artificial intelligence in healthcare, this table outlines a number of ways in which AI is being deployed in health and healthcare, and each of the boxes links to a real-life technology in development or deployment. But just to clarify, a technology's inclusion here isn't necessarily an endorsement of the technology or its provider, just to provide an example of some of the potential uses of AI. And on the left, we've got AI as a medical device, so clinical uses of AI, and then on the right, we've got some back office / administrative functions. But looking at the AI as a medical device, the clinical uses, we can see a lot of potential that AI can bring, and a lot of the areas that are being explored. So that includes things like scientific discovery, where AI can help accelerate drug discovery and deployment and development. There's also the potential prevention and promotion, where, for example, AI can play a preventative role by analyzing data from different sources. That includes things like wearables or electronic health records, or even lifestyle data such as physical activity, sleep patterns, etc., to predict and prevent health issues before they arise. Then there's also the opportunity for diagnosis, where AI has the potential to enhance diagnostic accuracy by analyzing medical images, and it can possibly do this more quickly and more accurately. For example, AI algorithms can detect early signs of diseases like cancer with high precision, and it can often outperform some of the more traditional methods of diagnosing these diseases. And this can lead to early intervention and patient outcomes. And then we also have things like treatment, where AI can assist clinicians in optimizing different treatment strategies, provide clinical decision support, support medicine compliance, or preoperative planning. And to date, unsurprisingly, most of the attention has focused on the attractive, or what is seen as the attractive clinical AI as a medical device. But there's also a lot of potential for AI in the back office or administrative processes, which often comes with far less risk, both clinically and also in terms of people's data concerns. But the admin or back office processes are not seen as glamorous, particularly by policymakers, so they're not often as advocated or encouraged or pushed as much. But we've seen through our research, there are a lot of areas where non-clinical uses of AI in admin, improvement, education can help save a lot of time. And we'll be covering some of the examples of AI being used clinically or non-clinically in a bit more detail. And I'll now pass on to Tom, who will look to talk through some case studies.
Great. Thanks a lot, Ahmed. So thinking about how AI could help to improve quality. So I want to just kind of dig into that in a little bit more detail and talk about two real-world examples that the Health Foundation has supported over the last couple of years. So the first one is a clinical example that shows how care could be optimized for a specific condition. So this project, called Project Breathe, was led by Royal Papworth Hospital, Cystic Fibrosis Trust, Cambridge University, and others, and was designed to improve care for people with cystic fibrosis. And here, data is recorded through devices used at home that measure lung function, things like weight, oxygen saturation, and other indicators, which are then all displayed through an app. And here, users can keep track of their lung function, while clinicians can monitor early changes, detect signs of exacerbations, and make better decisions about when to see patients or when to change treatment. Now, interestingly, this intervention includes a range of technologies, and it also includes an AI component that analyzes the data generated through those wearable devices and pulled through the app. And this AI model was shown to predict exacerbations up to 10 days earlier than antibiotics would normally have been given to somebody with cystic fibrosis. And this provides the opportunity to enable earlier treatment, which could then prevent lung damage and potentially avoid hospital attendance. The second example I wanted to share is in the non-clinical space, and this one focuses on patient feedback. So here we had a project led by Imperial College Healthcare NHS Trust, which developed a tool that uses natural language processing, which is a form of artificial intelligence, to analyze free text comments that are put into the NHS Friends and Family Test. And what the tool does is that it takes this data, this unstructured free text data, analyzes it, and then creates easy to read reports about patient experience and what kind of themes have been emerging from that feedback, and can provide those summaries at a service level or a ward level, and therefore giving frontline staff the information that they need to then design effective quality improvement interventions. And it saves a huge amount of time. So this model can analyze 6,000 comments in 15 minutes compared to 4 days, which is the time it was taking a member of staff to do prior to implementing the model. And then the time that's saved allows the patient experience team to spend more time supporting staff to act on patient feedback and improve services. And for example, Imperial have taken steps to improve communication with patients and also improve discharge processes. And while both of these examples are fairly small scale at present and require further testing and iteration, I think they show the potential of AI for improvement in healthcare. And there may also be a number of other ways that AI could support improvement, and we'll have time to consider this in the discussion later on. We'll move on to the next slide, please, Ahmed. So while AI presents a whole kind of range of potential across a bunch of different domains of healthcare, it also brings risks, which can be significant when you consider the complexity and the power of artificial intelligence and the safety critical nature of healthcare. One of these risks is a phenomenon known as automation bias. Now, automation bias occurs when a user accepts the guidance of an automated system and ceases searching for confirmatory evidence, perhaps transferring responsibility for decision-making onto the machine. Similarly, clinicians who use generally reliable technology systems might become complacent and miss potential errors, particularly if they are pressed for time or under a heavy workload. And obviously this can have serious consequences, particularly when an AI system is being used in clinical care. A study that came out of Germany and the Netherlands which was reported in the journal Radiology, showed how automation bias could affect radiologists at different levels of expertise when reading mammograms supported by an AI system. In the study, 2 randomized sets of mammograms were presented to a group of radiologists who were asked to categorize the images. The first set was a training set of images in which the AI recommended the proper or correct category, and then the second set consisted of incorrect categories which were suggested by the AI model. Now, the outcomes of this study showed that the radiologists were considerably worse at assigning the proper categories for the cases where the AI model had made an incorrect recommendation. When the wrong category was suggested by the system, clinician precision fell significantly, with that precision falling the most among the least experienced radiologists, which is probably what you'd expect. Yet even experienced radiologists, so those who have at least 15 years experience or more, saw their own accuracy fall, not quite as much, but still from 82% to 45% when the AI model suggested the incorrect category. So the question here is, what can we do to mitigate the risk of automation bias when we're using AI in healthcare? Now, this paper that I mentioned in the Journal of Radiology suggested presenting users with confidence levels of the system to keep users more critically engaged with the outputs. A separate study from MIT also showed that automation bias is more or less likely depending on how advice is provided. So here, AI models led to a better result or a more accurate result when the advice was descriptive, so for example, flagging the presence of something, as opposed to prescriptive, for example, recommending a course of action. We'll move on to the next slide, please, Ahmed. Another group of risks emerges as a result of poor data quality or data bias. So as Ahmed explained, AI is built using data sets, and so the quality of that data will have a bearing on the quality of the output it provides. And similarly, when AI is trained on data sets that include biases, the algorithm will replicate and entrench these biases, which could lead to discrimination or even harm. So looking at an example, on the slide, we have accuracy data from 3 facial recognition systems, which were assessed by the researchers Joy Bolon-Winnie and Timnit Gebru, who are based in the US. And in their experiments, the system's error rates in determining the gender of light-skinned men were never worse than 0.8%. However, for darker-skinned women, the error rates ballooned by more than 20% in one case and around 34% in the other 2. Bolon-Winnie and Gebru also point to another facial recognition system that claimed an accuracy rate of more than 97%, but the system's results had not been broken down by gender or by race. And when we look at the data this system was trained on, it was actually more than 77% male and more than 83% white. When we consider the healthcare context, there is, of course, a risk that data sets used for AI models, whether that's for imaging or for otherwise, do not accurately represent the full range of communities in our society. So I think here, all of this highlights the importance of a few things. So firstly, developing high quality, diverse and representative data sets. And the University of Birmingham have developed some really helpful guidelines on this through their Standing Together project, which I've linked to on the slide. Secondly, it also highlights the importance of scrutinizing AI at each stage of the development and implementation pipeline to spot and address biases. And then thirdly, using robust auditing and evaluation processes. Next slide, please. I also wanted to touch on the environmental impact. So AI also has an environmental impact, which will continue to grow as AI becomes more prominent. So AI requires quite a significant amount of computational power when it's being developed and when it's being run. And this obviously requires energy, which may or may not come from renewable sources. And then bigger models, such as forms of generative AI like ChatGPT, because they're such big models, can require huge amounts of energy. To put this into context, it's estimated that generative AI searches, or searches by generative AI models like ChatGPT, use 4 to 5 times the energy of a conventional web search. And it's possible that within years, large AI systems are likely to need as much energy as entire nations. And as we heard earlier, training AI models also requires significant amounts of data. And this data sits on servers that require cooling and ventilation, which also has energy and water requirements. And then beyond energy and water, AI also requires hardware, such as processing chips and data storage equipment, which have short lifespans and add to the already growing global e-waste stream, which is predicted to double by 2050. So again, the question is, what do we do about it? This sounds quite serious. How do we tackle this? How do we mitigate the environmental impact? Now, some experts, such as Kate Crawford, who's an AI academic, and on this slide on the left-hand side, has made some quite useful suggestions about what we could do to help reduce this problem. This could include things like developing more energy-efficient AI models, mandating the tech industry to measure and publicly report energy and water use, and then also incentivizing the adoption of renewable energy. So when that energy is used to build and run the AI model, it's coming from renewable sources rather than fossil fuel generated. So to summarize, I think it's fair to say that AI presents a range of risks and challenges, including the ones I've touched on here. There are others, but I think these are 3 of the key ones. And these are clearly significant and should be taken seriously. So I think what we need to do collectively is find ways to address them, and this will need to be aided by the right policy and regulation, which is something that Nell will pick up on in a moment. And I'll hand over to her to take us through the next section.
Thanks, Tom. So in addition to some of the issues that Tom has talked about, one of the really critical things to getting AI right in practice is making sure that the public and staff are on board with uses of AI. Now, that's not just about convincing the public and staff that AI is a good thing, but it's about genuine co-creation. And we recently surveyed 7,200 members of the public and nearly 1,300 members of the staff to ask them just how they feel about AI being used in healthcare. And I'm just going to talk you through a few of the results. There are more in a full publication, which is on our website, so do go and check that out if you want to see more. But here are the three that I think you might find pretty juicy. So one of the first questions we asked both the public and staff were, how supportive or not are you of the use of artificial intelligence for A, patient care, or B, administrative purposes? And what we found on the whole, on balance, both the public and staff are supportive of AI, both for patient care and for administrative purposes. So you can see here, if we look at those red bars, that's the UK public, we can see that 54% of them support it for patient care versus 33, and 61% support it for admin purposes compared to 28. So a little bit more support for admin purposes than patient care. And then if you look at those blue bars on the right-hand side, that's the NHS staff, and we can see they're more supportive than the public are of the use of AI in the NHS. And again, more supportive of the use of AI for admin when compared to patient care. Now, that might be for several reasons. One of the things that we found when we asked people about what some of their concerns were that about a third of both the public and staff told us they were worried that AI was going to distance them from patients or distance them from healthcare staff. And this is something we see quite a lot in the work that we do on public and staff perceptions, which is when technologies are perceived to come between a carer or a member of staff and a patient, they're generally less well received. So that includes things like video conferencing and chatbots as well. And we think that we might be seeing some of that here, and that's why there's a bit more support for admin purposes. That and the fact that generally they're more low risk as well. And so if we just click onto the next slide, one of the other questions we asked people was we asked the public to tell us whether they felt that AI was going to make the quality of healthcare better, whether they felt that it wasn't going to change the quality of healthcare, or whether they felt that it was going to make the quality of healthcare worse. And when we take the population as a whole, there's a pretty interesting split. So around 2 in 6 people told us that they felt that it was going to make the quality of healthcare better. Another 2 in 6 told us they didn't think it was going to change the quality of care. It's a bit of a split in opinion. But 1 in 6 told us that they felt that it was actively going to make the quality of care worse, and 1 in 6 didn't know. So the need for engagement there is so important to kind of make sure that people are aware of how AI might benefit them, but that we're also listening to their concerns. But what this graph shows is the breakdown of that question by age. And this is a finding that we've seen a few times now, and one that I think always catches people by surprise. So when we break down the answer to that question by age, if you look at that red line, that's the number of people saying they think that AI will make the quality of healthcare better. Who is the least likely group to think that? The 16 to 24s. And what we consistently see throughout the survey is that that young person age group, the 16 to 24 age group, are the most skeptical, both of technology as a whole, but particularly of AI. They're the least likely to think that AI is going to improve the quality of care. So we think there's sometimes kind of a widespread assumption that young people, they're on social media all the time, they're always on their phones, they know how to use tech, they've grown up with it, so they're just inherently more accepting. But actually, what our survey work is now showing for the second year in a row is that they are generally the group that is the least accepting of AI and technology in healthcare. So it's something really important to bear in mind when you're doing any sort of engagement around this subject. And then just the next one. So one of the other things we were interested in is kind of what was the value that people were placing on keeping a human in the loop. So not just letting an AI system kind of automate and run automatically, but what value do people place in having a human as part of any decision making? So what we did was we gave members of the public 6 different scenarios. So we said, you know, are you happy or not with AI creating letters, taking down any appointment notes, predicting disease, supporting diagnosis, things like that. And we said, tell us, would you be happy or would you not be happy? Half of the sample were told that a human was going to check the results, and half the sample were told that a human was not going to check any output or results. The red bars on the left-hand side were from the scenarios where the human was going to check the results. And these are calculated if we take the number of people who said would be happy minus the number of people who said they wouldn't be happy. So you can see here things like creating letters and recording appointments, it's plus 39 percentage points. So on the balance, really supportive of that. And actually, in all 6 of these scenarios, the public on balance support the use of AI for that when there is a human in the loop. But when we take that human out, when we tell people it's not going to be checked, you can see there that massive swing to the negative. So now on balance, they don't support that. There's a little eke of support for creating letters, but it's dropped 37 percentage points. But when we look at things like supporting diagnosis, that goes from +19 to -40. So people really, really value knowing that there is going to be a member of staff there to check results and check accuracy, because we see that the accuracy of decision making is a major concern to the public. So if you're thinking about using AI in a service, that's something to bear in mind. People want to know that someone is involved in that. So if we go on to the next slide. So one of the other publications we've had recently is around, we think there needs to be a dedicated strategy for AI in health and care. There isn't one at the moment. And what we see is there's a huge amount of activity in this space. You know, you'll all be familiar, you open up any sort of digital health website and there's something new every day about AI. But one of the problems is there's a lack of coordination and there's a lack of collaboration happening at the national level. And as a result, this fragmentation means that our activity to boost AI in the NHS is currently less than the sum of its parts. So we've recently published a report, both calling for the use of a national strategy, with saying crucially that has to be about responsible AI. And that's about not just minimizing harms, that's not just about making sure it works for most people, but that's about making sure that it works for all people, for society and the planet, thinking about what Tom has said about the environmental impact. And within that, we say there's 6 priorities that you kind of need to really focus on if we're going to make a go of this, if we're going to really achieve that potential of AI systems. So the first one is about making sure that AI is shaped by public, patients, and healthcare staff. And again, it's not just convincing them it's good, not just selling them a product. This is about genuine co-creation, genuine co-development. The second one is about making sure that we focus AI development and deployment in the right areas. So thinking about what Ahmed said about the fact that we're perhaps the balance isn't quite right. We're focusing quite a lot on the clinical side of stuff. There's much more that can be done on the non-clinical and back office end. But also what we find is that the availability of AI tools is being driven primarily by where industries think AI is needed, which means there's a lot of off-the-shelf solutions ready to procure. But what we're seeing is a lot of trusts are being overwhelmed by the amount of AI solutions that are being offered to them. And it's less likely that those solutions are going to be right for their needs and their populations. Or we're seeing AI available in areas where data is already readily available. So that's why we see so much AI in things like imaging, because imaging data has been collected for a very long time. It's quite high quality. And so that's where there's a concentration. Does that necessarily mean we need more imaging AI? Actually, probably not. There's a huge number of systems out there. There's loads of processes and ways of working and pathways that with the right data could really benefit from AI and being used to improve those systems. So that's really worth thinking about as well. We also say that we need to think about data and digital infrastructure. It's hard to imagine AI being used on kind of systems that are running on 20-year-old operating models or systems that take 20 minutes to log on. So until we get the right systems to collect data, store data, share it, computers that work, it's unlikely that we're going to see the benefit of AI. We need to improve digital maturity. We also need to make sure that we're getting evaluation right. Evaluation of AI models is really tricky. They've got some quirkiness to them, which makes them quite difficult to evaluate. We need to be thinking about how we kind of come up with new and innovative evaluation models so we can be sure that AI is working in the way that we think we want it to work. And then we need a clear and consistent regulatory regime. And I know there's a question about this in the chat, and I'm going to come back to it as a question, so I don't take more time here. But essentially, at the moment, there's a lack of clarity on regulation, and that's causing confusion. Clinicians are unsure where their liability sits for these AI systems. Innovators are unsure about what they can and can't do, or even what they may or may not be able to do in the future, and that's holding back innovation. So it's really important that we focus on driving some clarity around regulation. And then absolutely crucially, staff need the right skills, need the right capabilities, and they need the time and resource to be able to focus on AI. We need to have roles that are dedicated to really understanding AI systems and using AI in care and non-clinical processes. And we need to make sure that staff are involved as their roles evolve. Like Ahmed was saying, they're unlikely to lead to widespread redundancies in healthcare, but we are going to see roles evolve and staff need to be engaged in the way that happens. So again, the wider paper on this is available on our website, so do check that out if you want to read some more behind each of those. But to finish, what I wanted to do was just kind of give you some food for thought, some questions to think about if you're thinking about potentially using AI or changing a pathway using AI for doing quality improvement. So here are kind of 3 nuggets that will hopefully help you think about this. The first one we say is start with the challenge, not with the technology. Often what we see is that people are kind of pitched to technology and they think, oh, where could we use this? Where might this be helpful? And actually, it's not about shoehorning a technology into a pathway. It's about starting with the challenge of saying, what do we want to improve? What is the ultimate goal? Is AI, is technology going to be the right thing here? So thinking about what is the problem, starting there, and is this somewhere where AI might help? Often, it probably won't be. It might be just a basic statistical function that you can use in the data you've got. It might not even be technology at all. It might just be about having a person kind of change focus or perhaps get a little bit more capacity. So we're always thinking critically about, actually, is AI the thing that we want here? And like we've said, public and staff engagement and support are critical. If they don't support the use of AI in that service or that pathway or that process, they're not going to use it. And it's ultimately just going to be a waste. So we really need to think about, our staff and the public happy with AI being used in that way? And one of the key reasons why I use the term public and not patient is because increasingly AI is being used for things like risk prediction, and we're talking about engaging people who aren't active patients, who aren't active users of that service at that moment. So really important not just to think about the people who are using it now, but is it acceptable to the people who may be using it in the future? And then also thinking about the co-design solutions. How can I involve people in the co-design? How can I make sure that it's right for them? We've really understood their needs and we've designed a technology that's going to work for them. And then lastly, it's absolutely critical to think about implementation. And what we often say is fund the change, not just the tech. You can't buy a piece of kit and expect it to make a difference. How well you embed that into your system or service is where the success of the technology will live or die, essentially. So we really need to think about what skills and resources are you going to need to implement that technology into the service. And then also think about how might the use of AI fundamentally change this entire pathway or process. We see things like AI-enabled MRI scanners are great and they can process results 3 times as fast. You go, well, have you got 3 times the number of staff who then look at them and do things with them? Have you got the capacity further down the line to then do those follow-up appointments or find those other things? Because if the answer is no, then actually you're just going to cause a massive blockage later down your pathway. So really important to think about that knock-on effect across that whole pathway as well. So hopefully that is helpful. I know we've got some time now for Q&A, and I'm going to hand back to Matt, who is going to take us through that. Thanks, Matt.
Okay, thank you so much for that. That was absolutely brilliant. I definitely feel a lot kind of smarter and better informed after listening to that. Lots of kind of inspiration, wasn't there? Also some kind of like serious considerations raised as well. And those really important kind of key takeaways from Nell at the end. So like you said, Nell, yeah, we've got time for 2 or 3 questions. Quite a few have already come through. You flagged one. So we'll start with that. It's around Helen and where I actually have asked around kind of regulation, where the thinking is at around that, where the responsibility kind of lies for kind of governance and regulation as well. So yeah, I think you wanted the chance to say a bit more on that.
Yeah, thanks for that, Matt. So regulation's a really interesting question. So one of the things that makes regulation quite difficult when it comes to AI in healthcare is the quirkiness of AI systems, essentially, when compared to other types of technology. So, for example, some algorithms are called adaptive, and that means that they will change their behavior over time as the data that they're based on also changes, which is obviously great because it means they can keep up with wider shifts. But it also means that if it's been regulated and approved based on its initial application, as it starts to vary, it can do things like stray, which is where it gets a bit further away actually from where it should be, or it can start churning out results that we weren't expecting. And because there's usually a lack of transparency in these systems, it's really hard to understand why they've come to those decisions. So that's hard to regulate. But on the other side of that coin, you have static models. They're the ones that don't change. But if your population data changes, if your population as a whole starts to shift, that algorithm is not going to keep up with that changing shift, and it's going to become less accurate over time. So there's a lot here about post-deployment surveillance and making sure that algorithms are, how often do we check on them? How often do we make sure who's responsible for that? That all needs to be worked out. And another thing is as well about some of the AI we see coming through are things called foundation models. So that's AI systems that can be adapted to do a variety of different tasks. So what we can happen is that we can see a specific use of an AI model regulated and approved, but then lifted and shifted and used for a different purpose. So how do we make sure there's sufficient regulation and monitoring if an AI system is being used for a different purpose than what was originally intended? And then another issue is the speed of development. There are so many of these models coming through, and they're coming through really, really fast. One, that means that traditional evaluation methods, your 3-year RCTs, are not going to keep up. By the time it's concluded, it's about 6 models old. So that's really difficult. We need different approaches to that. But also the capacity of the system. MHRA and NICE are overwhelmed by the number of AI systems coming through to be approved and regulated. They need more capacity to be able to keep up with this, what Sam Roberts previously called a tsunami of innovation. And then, so that's kind of like some of the difficulties of regulating based on the AI system itself. And then I can see another question's come in as well about the EU AI Act. So one of the other challenges we have is kind of what is the UK's regulatory stance? And under the last government, you might have seen there was a white paper which they called a pro-innovation approach. And what they essentially said was that sectoral regulators, so people like MHRA, have got this covered. We don't need any additional national level legislation or horizontal legislation in order to regulate this technology, because we think that's going to get in the way of innovation. But actually, is that strictly true? Pharma is one of the most heavily regulated sectors in the world, and yet is one of the most innovative. And with the EU having the AI Act, which is sectoral, horizontal legislation, and has been quite strict in having a kind of risk-based governance, there's a massive disconnect between the UK approach and the EU approach. And that's confusing people. It's confusing innovators who, let's be honest, they're not building a system just to flog it in the UK. They're going to want to sell it probably in European markets. They're going to naturally try and adhere to those stricter standards. So what we're expecting to see is what they call the Brussels effect, which is essentially where the European legislation kind of becomes the default. Now that might change. The King's Speech kind of referenced that we might be having an AI bill coming our way, so that might shift, but we will have to see. Hopefully that answers your question.
Yeah, definitely. Great stuff. Okay, I'm going to go back a bit actually to one of the first questions that came from the chat from Aranan. And apologies if I'm not pronouncing your name right, but it was, I think we see this often with tech, don't we, that the NHS can be reliant on kind of consultants or the private sector to kind of drive some of the changes. So they ask, any ideas or thoughts on how we can kind of improve the conditions for change? So that I guess that could include things like information governance, ethics, access to data, and other kind of those fundamental conditions for change to allow then staff more kind of on the ground to more readily and responsibly kind of apply AI. Any thoughts on that?
Yeah, I can excuse me, I can kick up on that one. I think that was a question that I was typing a few thoughts in response to in the chat. I think it's complex, isn't it? There are quite a few different domains that you need to kind of improve the maturity of to build those conditions for change. And I think in the chat I was talking about, that some of the technical requirements, so around the digital infrastructure, electronic patient records, getting those up to maturity, improving cybersecurity, internet connection, Wi-Fi, getting the right hardware and software. To be honest, the foundations, really, digital foundations, because if they're not up to scratch, then you're going to struggle to bring in AI or any other form of kind of more sophisticated technology. So there's a technical digital infrastructure piece, which I think is really important. There's also a kind of human capability side, I think. So building the kind of knowledge and awareness of AI and innovation more broadly, I think, among staff, and then also the kind of the skills and the abilities that you need to start identifying problems and think about where AI could be brought in. Health Education England, before it was wrapped up into NHS England, did some really interesting work to try and determine what kind of capability different, I suppose, archetypes of NHS staff will need in terms of like knowledge and skills, because it's obviously not going to look the same for everyone. Some people will be much more in the kind of mold of shaping innovation, shaping AI policy and implementation within an organization, others less so. But there's definitely a sort of foundational or basic level of knowledge and capability that all staff are going to need. And then the kind of more advanced level will vary according to that person's position. So I definitely think there's a kind of knowledge and skills piece. But then there's all this, there's a kind of governance, IG, there's a piece around procurement and understanding the market and what's available and then the evidence behind them, which is something that we've been thinking about and thinking about how we can support NHS organizations to better understand what's available and how AI may or may not help them. So I think there are 3 areas, but clearly there's quite a few different facets to this, which, there's no kind of simple answer to. I don't know, Nell and Ahmed, if you wanted to add anything to that.
No, I think you've covered it for my purpose.
Great stuff. Okay, well, I can see there's lots of other questions come through on the chat. Actually, Ahmed, Nell and Tom have been generous in kind of responding to some of those as we've gone. Really keen that we've got enough time for kind of discussion together. So we're going to push on, if that's all right, to the next section of the workshop, which does provide a bit of an opportunity and space for us to actually discuss some of the issues that have been raised in small groups. I'd really encourage everyone to kind of stay on the call for this. It's a great opportunity to kind of learn and share from colleagues. It's also actually an opportunity to inform Q's thinking and Q's kind of work in this space. So this is how we're going to do it. Take all of that kind of food for thought that we've had from the panel so far. We're going to have 15 minutes in groups of around 8 to just explore these 2 broad and important questions. So firstly, what are the biggest kind of challenges that AI could help address and how? And I think we've had some inspiration on that from the panel, haven't we? We've also had this call, I think, from Nell to really focus on first, what's the challenge that we're facing and how can AI help address that, rather than being led by the tech or led by the kind of applications. Let's be really like challenge led in how we think about applying it. And then secondly, what support do those improving care need to maximize the potential for AI? So that could be training, resources, guidance, peer learning, some of those things around kind of regulations, all those kind of conditions for change that we've already started to pick up. It'd be really great to kind of draw those out. That'll particularly inform Q's work in that area. So Char's going to send everyone off into those groups in a second. Please do just kind of self-facilitate the groups. You don't need a note taker in the groups, but once everyone's come back from the breakout, we'll actually ask everyone to add their freshest thinking on these 2 questions to a Slido so they can really kind of consolidate the learning from the discussion. Okay, great stuff. I think Char is going to fire us all off in a second. Have a great discussion, and we'll see you back in 15 minutes or so. Okay, great stuff. I think everyone's back in the main room. So thanks so much for that. Sorry to cut those discussions off. Hope you did have a really good discussion. We're actually going to go straight into a Slido now. So you can see the link on the screen, slido.com again, and the hashtag is AI Health. And we just want you to kind of consolidate your freshest kind of thinking around those 2 questions. So just take a few minutes to do that. It's a really good way for us to kind of consolidate some of the learning from the session. We won't share the responses here, but we will kind of summarize them and share them afterwards. So please do just take a few minutes on that. Fabulous. Thanks so much for doing that. Keep typing away. That Slido's not going anywhere. But just while people are typing, it'd be great if we had 1 or 2 volunteers actually from the group just to share their freshest thinking. So on that first question, what are the biggest challenges that AI could help address and how? So if you're happy to share a little bit on that, just pop your hand up, come off mute, and it'd be great to hear from a couple of members of the group. Who's going to help me out and go first? Great. Lise, do you want to come on?
Just because I hate an awkward silence and I have to fill it.
It saves me, thank you.
I think there was a couple of themes in our group. One was around just sort of admin grunt, taking the admin grunt out of lots of things that we still do in a very manual way in the NHS, be that meeting minutes, be that writing reports. And I think before we get too excited about sort of diagnosing patients and treating patients with AI, I think there's some real just back office admin grunt, and including that includes admin grunt that professionals clinical practitioners are having to spend a lot of time writing reports, etc. I think AI could do us a blooming good first draft. You'd probably still want a human being to check it. And then there was also a conversation around self-help, and Tom Brooks was in our room, who's worked in and around this agenda or tech in healthcare for his career, which he's now in the sort of autumn of that career. But I think he was saying we were ahead of the pack and we've now fallen to the back of the pack. But, a lot of other countries have recognised that there aren't enough healthcare practitioners. There'll never be enough healthcare practitioners to meet demand. So what opportunities could AI present in terms of signposting to self-help? And then we talked about, algorithms to support referrals going to the correct services, etc. So I think that probably sums up the sort of two themes that spring to mind from our group.
Fabulous, great stuff. Admin grunt, I think that's a good name for a AI software firm, isn't it, or package? But I think
I'm here for that.
Yeah, exactly.
And I think I shared it with my guy. I'm a big user of AI, partly because I'm time poor, and I think I've got a task to do, but I haven't got time to do it properly. I'll get AI to do me a good first draft, or if I've got a long document to read and think, I'll just get it to do me a summary, and I'll read the summary. And there's a lot of nervousness from our IG, and of course I don't put anything in there that's confidential, but there's still a lot of nervousness about where's this data going and these language models that are learning from what you've put in it. And I liken it to, imagine on a winter's day when there's 3 foot of snow outside and there's a great big shiny brand new snowplow sat there, and they say, Lise, I know you want to use the snowplow, but can you just go out and use the shovel? I'm going to be so tempted to get into that snowplow because it just does take away some of the grunt of some of the hard stuff that and I think if we don't get the framework and the IG wrapped around it quick, people will start using the snowplow whether we want them to or not, and that's a real risk then.
Great stuff. Okay, yeah, really, really fantastic to hear those thoughts. Have we got a volunteer on the second question? Kind of what support do those improving care need to maximise the potential for AI? So more, hopefully people moved on to that kind of second question in terms of support needs. Who's going to help me out there? Just pop your hand up and unmute yourself and share with the rest of the group. Tim, go for it.
We just need permission to innovate in areas that are safe. That's all we need.
Great stuff. So that more kind of permissive culture, obviously taking some of the cautions on board as well, but that kind of permissiveness. Any advance on that or any other thoughts on that kind of support that is needed? Anything more specific? Like you say, Tim, there's that kind of overarching culture, isn't there, of permission? Any more specific supports that came up from the discussions? Wade, do you want to come in?
Yeah, I think on that note, I think the early buy-in from the different stakeholders, particularly the people you're actually trying to improve the processes for, like the clinician, getting them involved and buy-in from the early stage, I think is crucial.
Great stuff. Thanks very much. Probably time for one more. Arangan, were you hoping to come in there? Yeah, great.
Yeah, I'll come in. My perspective is that we need some support from higher up at NHSE, Health Foundation, etc., creating or supporting those conditions for change, guidance like on information governance, ethics, access infrastructure, digital health. What does an organization or an individual member at an organization need to deliver an AI project? But in terms of actual projects themselves, we need them done as close to where the care or the problem is occurring by staff, patients, families. And so rather than buying in external organizations, consultants, we need to be able to create the capacity at a local level closest to the problem to actually deliver those specific projects.
Yeah, great stuff. Yeah, and that came up a bit from some of the earlier questions. This question of kind of who's driving the change at what level, what's needed at the national or even international level versus the organisational or even, you know, within people's specific roles. Okay, great stuff. So unfortunately, we do need to move to the wrap up. I think this conversation does have more legs, doesn't it? And we are thinking within Q at the moment around what we can most usefully do to kind of support members in this area. But just before you go, it would be great if, firstly, if you could just share in the chat kind of what your key takeaway from the discussion is. So just spend 30 seconds or so. What's your key kind of takeaway from this discussion? It'd be great to hear that. And just pop that in the chat. Keep those coming in. And then we're always looking to improve our workshops. And we'd really love to hear kind of what worked well or what could have been done better. So again, just in the chat, if you could just kind of type what went well, if you type www and then you comment on what went well, and for even better if you just type EBI and then you comment on what would have been even better. So if you just do that in the chat, that'd be great and much appreciated. Great stuff. Please do keep those coming. Lots of what went wells, actually. If there are any even better riffs, please do add them. That really helps us kind of improve. And finally, just before I get to the thank you, Shah's just going to launch a really quick evaluation poll that we have in all of our webinars. It just takes 10, 15 seconds to complete while everyone's responding to that. Just a final massive thank you to everyone for joining the session. Really great contributions from everyone. And special thank you to Nell, Tom and Ahmed for such interesting presentations and workshops. So a huge thank you to them. Great stuff. Thanks very much, everyone. Thanks for joining and have a great rest of the day.